Okay, everybody. Again, thank you for being at the Care Answered webinar. You are at Safe Road Home, the transition from hospital to rehab center to home. So we're going to cover a lot of those topics. And I'm going to just start right away by letting you know the topics that we're going to cover. So first, we're going to cover preparing for a hospital transition and then preparing for skilled nursing transition and then preparing for home. My name is Nicole Christensen. I'm a patient advocate and a CEO of Care Answered. I'm also the author of From Crisis to Calm. And I'm here with my colleague and friend, David Fielding, who is also a patient advocate, and he's with Engaging Solutions. And he has MPH. He has over 30 years of experience in executive experience in healthcare administration. And I'm so glad that he's here. He's been a part of the Care Answered team. We have shared clients, and he has a lot to offer us today. So without further ado, let's get started. I will say that the preparing for home, the third step that I just mentioned, we're going to cover, but I've been speaking with people that were interested in this topic, that could be a webinar all in itself. So stay tuned because we're going to offer more information and detailed information as things are changing very rapidly, as we're all aware of, okay? So the first thing I want to talk about is getting ready to go to the hospital. I apologize for those of you that have been in my webinars in the past. I don't mean to beat a dead horse, but I find it so very important at this time. So many of us, whatever we might have to go to the hospital for, we are likely going alone. So for that, we need to be prepared so that the folks in the hospital, our clinicians, the caregivers there in the hospital, know as much about us as possible so that they can make the best care choices in the heat of the moment that they can. So I suggest creating a kind of grab and go for the hospital. Just like women oftentimes, if they're pregnant, kind of close to the end, close to their due date, they have things prepared at the door ready to go. This is the same kind of thing. Okay, so what I suggest is getting a face sheet or a face page that has your name, address, phone number, date of birth, any allergies you have, emergency contact information, including telephone, email, text, what they should know about you that's not going to be obvious. So again, so that they are equipped with as much information as they need at the hospital. A medication list, medical conditions, past surgeries, past hospitalizations, a current physician list. Those are your physicians in the community and their contact information, copy of insurance card, HIPAA release forms, if you can get your hands on those. That will allow your loved ones to be able to contact the hospital and actually get the information. If you are incapacitated or not able to tell them, this will be very helpful so that your advocates, your loved ones, can really get the information that they need quickly. Healthcare proxy form, again, one of those things I talk about ad nauseum, but so important. You know, selecting those that can make your healthcare decisions for you if you become incapacitated, and having that conversation with them to make sure they know what you want done and your care needs. Any kind of healthcare directives, power of attorney. Again, this is for if you become incapacitated, that there's somebody to make your financial decisions for you. This is the way it generally happens. Healthcare and money unfortunately go hand in hand. So you want to make sure that your healthcare proxy and your power of attorney both know your wishes and concerns regarding your healthcare and your power of attorney for everything else as well. Also have with you a charged cell phone and its charger. In the height of the pandemic here in New York, we know that people were potentially going to one hospital and then ending up someplace very different. So hopefully we will never see that again, but it's better to be prepared so that, God forbid, some other confusion happens, they have all the information they need so that, again, your advocates and loved ones know what they need to know. So now you're transitioned to the hospital.
Noel, just one quick thing. It's important to use like a P-touch and label that equipment, because if it gets separated from the patient, it will disappear.
Okay, that's a good point. One of the things is also, now we're at the hospital, okay? So we're always preparing for discharge upon admission, okay? As soon as we get into the hospital, we're figuring out how to get out and what we'll need to be safely home, wherever home is. So the first thing is to find out who is on the care team. That communication is so vitally important. And again, having that HIPAA release, having that information on you is going to help ease that communication for your advocates and loved ones. So find out who is on the care team, your doctors, your nurses, what floor you're on, obviously, all your social worker, everybody that's in charge PT, if you're getting PT in the hospital, everybody that's involved in your care. And then I've had actually really good experiences with my clients of being able to communicate directly and have that information faxed to me. But for those that many, average everyday people, faxing is antiquated, so you might not have that. But the portal is also an extremely important tool. So accessing your loved ones' information via a portal, and they will give you access to that at the hospital. Again, having the HIPAA release will make that a lot easier, or healthcare proxy will make that a lot easier so that you can know, hopefully in real time, what's going on. The reality is with portals is it's often not in real time, because the ether or input, a person has to input that information. So again, that constant communication with the team is going to be vitally important. The other thing that I want to talk about is baseline. I say this because if we have the unfortunate incident of having to go to a hospital, you have to imagine that they see you as you are. So they may not be as informed, the team at the hospital may not be as informed of your baseline as one would hope. So for example, somebody walks a mile a day, they fall and they break their hip. Now, obviously that's pain, they may need surgery, all of those things, but the understanding that I used to walk a mile a day is helpful into what we're looking at as far as where we need to be to get me, if I'm the example, to where my baseline was. So having that information and communicating what somebody's baseline is, I find very, very important. Now, obviously, we're also in a pandemic. So there's other precautions that we're talking about and other concerns. So asking, obviously, if it's something you're being hospitalized for that was planned, find out beforehand any kind of COVID precautions, what they're doing, what's visiting it is like. I also put vaccine here. I haven't had a lot of experience with my patients, my clients, I should say, recently that got vaccinations in the hospital while in the hospital. I believe that has a lot to do with logistics, right? If you're not going to be in the hospital for 2 weeks, the logistics of where you're going to next be and getting your second shot and that kind of thing. But when I'm done with this slide, if people have thoughts about that, I'd love for you to share them so that we can all know a bit more. But certainly visiting is different at this time. If they allow any visiting, that's going to depend upon the hospital. I had a call a few weeks ago about their grandmother was in the hospital for non-COVID related reasons. But she was, I guess, COVID suspicious. And so they did a test, and I was contacted over a week later. And this woman, wasn't allowed any kind of visitors under the suspicion that she had COVID. And they didn't feel that it would be detrimental for her not to have a visitor. The family thought absolutely the opposite. They knew her well, and they said if she doesn't have any and she's all by herself, she will not heal. She will not cope with this, and she might not get out of the hospital alive. And so, but the fact is that they were waiting so long for the COVID test results. That was just so strange. And so what I did with them is just advocate to get because they were out there somewhere. The results were out there because it doesn't take that long. So we were finally able to get it. But the point is that I'm saying is that what are they doing regarding COVID testing, if that's a concern? And what does that mean for the family? And will there be visitors and how that will go? Those are questions that you are very appropriate to ask and to find out. Going to the websites of the hospitals can be the first step. Potentially going to the patient advocate in the hospital can also be a good step. In this case that I was talking to you about, they had done all of those things but needed additional help. But she did get her COVID test. It ended up being negative, and they were able to visit her. So it was a success story. Also, while your loved one or client or friend, what have you, is in the hospital, making sure that their community team, their health community team, also know that they're in the hospital and keep them updated as to what's going on. Because again, the whole care team as a whole can make sure that these transitions go the way that they should if everybody is working together and that care is more coordinated. And then we come to the right to appeal discharge or an unsafe discharge. Unfortunately, so many of us have had the misfortune of having this happen or hearing of this happen. So if you feel that your client or loved one is not appropriate for discharge, whether that discharge is home or to a skilled nursing facility, then you have the right to speak up. And you have the right to make sure that their care is looked at primarily and their safety and care. And if there's anything that is misunderstood, not understood, not clear, in any way confusing, then it's an unsafe discharge. If you are that person's person, if you are the loved one or you are the advocate, and it's not clear to you how they're going to safely be able to go to whatever transition they're going to, then keep asking until you find out. And until then, it is an unsafe discharge. So know your rights. There's also, we all have rights as patients. We're all patients. So there is a patient bill of rights. Look through it. It's one of the resources that we'll share at the end to make sure that and empower you to ask all of those questions and to know what your rights are. Do we have any questions or comments in the chat regarding vaccines or anything about hospitalization?
No chat questions.
Okay.
I just have one comment. One of the things that's happened because of COVID in hospitals is that they're not providing the paper, the documentation of the notice of determination of coverage and the discharge appeal notification. Oftentimes it's sitting at the bedside with the patient. If the patient can't access it and deal with it, the family or the advocate may not receive it. So they need to know to ask for that specifically. If they don't, then just a hospital social worker telling you that they plan on discharging mom tomorrow is sufficient notification. They're cutting corners, and it's unfortunate, but it's happening. And it's really important that as advocates, we know to ask for that documentation. It's required, but they're not giving it.
Or they are giving it, but not to somebody that can do anything about
Or they're mailing it,
it,
which
right? Which comes
long
after the fact.
after the discharge, you'll get it. You're right.
That's, thank you for adding that. I haven't had that experience yet, but it's good to be equipped for it. Okay, so preparing for a nursing home or rehab, a skilled nursing facility transition from the hospital. So one of the things within the hospitalization is that in that communication, and as David was just mentioning, what the discharge plan is, all of these things are very important to be on top of, because again, we're talking about discharge as soon as we're admitted. That conversation should be started. So nobody wants to ever be caught off guard. We need to be able to do our research for the appropriate, if rehab is the next step, what are appropriate rehab facilities for the patient. So one of the things I brought up here, and many of you professionals on the line, I know you know about it, but for those who are not professionals, I thought I would just spend a few seconds showing how it works. So this is the Medicare.gov compare. Let me see if it'll work if I go into it. Let's see. Oh, it does. Okay. So Medicare.gov, you can see, I'll see that, I am assuming. You can go in there and they compare everything. And this is not the end all be all by any stretch of the imagination, but it gives you some understanding when you're given a list of 20 potential rehab and you have no idea where to start. So it gives you, and it's a snapshot in time, because it's not like it's updated every day or every week or anything like that. So it has different comparisons for different kinds of facilities and services. So we'll just go into the nursing home, and I'm just going to put Philadelphia. Sorry for anybody that might be from Philadelphia or in Philadelphia now. I am not judging. I'm just showing you the site. So what we're doing is, so we've gotten these and we just want to compare them. So take randoms and compare. All right, so it has some overview, some information about the different nursing homes and rehabs. And all of it is relevant and important information that people should look into. But I want to take a moment to just point out staffing, because I find this to be so very important as far as discerning the care needed and the care that will be provided from a skilled nursing facility. Again, this is a snapshot in time. You also call and ask these questions specifically, and that changes day by day as far as staffing is concerned. So if you go in here, you will see the staff rating, the average number of residents, blase blue. Okay, so registered nurses hours per resident. So you'll see how much time they're able to give their different patients. So you'll be able to see that. And I think that, and the LPNs as well, nurses aides as well, physical therapists. I think a lot of that is very important. How much care, how much time of care that your loved one, your client, your patient will be able to receive can tell you a bit about it. The other thing that I suggest folks look at is whether it's a short-term or long-term situation. If you know that already, you can look in there and see what is relevant to your person. So quality of resident care. So it'll have short stay residents, and then it'll have long-term residents. And if you have something that's specific, right, that you know your loved one often is susceptible to bed sores. So you want to see, okay, how are they doing with that? And so you can see based on your information, limited or not, maybe how they'll be able to treat that for your particular loved one or client. So it's a good tool. Again, I am not saying it is the end all be all. I'm just saying it is a good tool. And then those conversations and calls, but we can't go there anymore, right? We can't visit anymore, which is generally what I would have said to do. So we have to use a different mode.
RNs do assessments, LPNs do meds and treatments. They cannot do assessments by license. So you're really looking for RN coverage for clinically complex cases. For those that require respiratory services, you have to ask how often are the respiratory therapists on site? How often is the pulmonologist on site? And because of COVID, you can also ask if they have a nurse practitioner program, or how frequently the attendings and the specialists come into the facility, because the on-site medical care is critical for complex cases. And last but not least, because of COVID, you might want to ask if they have an infectious disease consultant, and if they have an infection control nurse assigned, because that requirement was eliminated from the federal regulations in 2018.
Can you talk a little bit more about the infection control practice? I had thought that only just began recently. I didn't realize that that had been ended.
Previously, in fact, every facility was required to appoint a nurse, an RN, as to the position of infection control coordinator in the facility. And when they looked to eliminate unnecessary regulations, they determined that that one was unnecessary, and the feds dropped that requirement. So it became an option, not a requirement, in 2018, before the pandemic. Once the pandemic came out, it suddenly looked like a really bad decision. A lot of proprietary nursing homes dropped that position as soon as they were told it wasn't mandatory, and saved the money and put it in their pocket. The more responsible facilities kept it because they understood the importance of having somebody that specializes in infection control practices, because they're dealing with, too many infections, too many bacterial infections, whether it's VRE or MRSA, or even C. diff. You need the specialty area, and not every nursing home has an infectious disease specialist on their staff. I think they should, but they don't. So you might want to ask for that. That shows their commitment to the level of professionalism and clinical service. If you don't have the specialist on your staff, there's no guarantee you're providing or meeting that professional standard of care.
Thank you for that.
Yes, thank you so much, David. So the next point I would like to make is the therapies that they offer. I think David can attest to this too, unfortunately, as patient advocates. So they'll give you a list sometimes as a loved one, but it won't necessarily, the list of skilled nursing facilities may not have all the therapies that your loved one or your client actually needs. So that is an important factor in there. So if they need some kind of respiratory therapy, or they're on dialysis, something like that, and that site doesn't have it, then obviously that's not a good fit. So making sure, again, it goes back to that communication, as David mentioned as well, to know what the needs are so you can make the best choices. And another question is, how often do they offer whatever the therapies, whether it's physical therapy, occupational therapy, whatever it is, speech therapy, how often do they offer it? Obviously, it's going to be prescribed for a certain amount of time, but you want to make sure that they offer it for an appropriate amount of time, 5 to 6 days a week.
Right.
What is the visiting schedule, or what virtual methods are used for visiting? Again, we're not able to go in and out and see our loved ones like we used to. So we need to know what that is and to make sure it's being done. And then we'll talk a little bit more about who would be doing it. And if somebody has a condition that would make participating in the rehab difficult. So that happens time and time again. It can be something as simple as pain that nobody's addressed. So therefore, they're no longer participating in PT because they don't want to get up because their back hurts so badly, and no one's addressing that. That's a simpler case, you would think, but there's also things that are more compounded than that. One of the things that come up a lot is any kind of other therapies. If there's cognition difficulties, that's generally not where a skilled nursing facility thrives. So what can you do or have in place to help? Or if there's medications that skilled nursing facility does not offer, they can't easily get. Maybe it's more expensive. Maybe they're not used to getting it and there'll be a delay. But unfortunately, a delay is not an option because they need that medication to live. So there's things like that that happen that we want to make sure that wherever rehab or skilled nursing facility that we are suggesting for our clients or loved ones, that they are equipped to deal with all of those things. Then I often tell folks to know how long it takes them generally before they do a care plan meeting. They have a certain amount of days, and I've spoke with some skilled nursing facilities that say, well, we don't even think that this client will be here that long, and we have, let's say, 7 days to do it. That's really not okay for the health of the person that's there. So if it's not an actual care plan meeting, make sure that you know when you can at least speak with all of the care team, whether that's individually or not, to make sure that everybody's on board. Because certainly don't have to wait to a care plan meeting to make sure that your concerns are noted and addressed.
Nicole, I just had this experience today, actually.
Oh, really?
It's so important that advocates be proactive in this area. It was a wonderful facility. I was happy that the client was admitted. And when we asked about the care plan, they said, oh, well, it'll be in a week or two. Well, this is a critical case, and the family is not going to wait a week or two to know what's going on with their relative. So we had to be proactive to demand that we have something scheduled, just so that everybody on this webinar knows the initial assessment by all disciplines is done within 48 hours. Once that's completed, typically what happens is that each discipline will contact the family. That's a very disjointed process for the family because it's not a coordinated or collaborative care plan.
Right.
It's each individual discipline's assessment. The full care plan is really done over the first 7 or 8 days, but they generally can meet by day 3 or day 4 to give you a good impression, at the very least, of what issues were triggered and what will be addressed with the initial care plan. And that's really important to reassure families that all of the critical things are addressed. And if something isn't, the family can raise that issue and they can revisit it.
Excellent. Thank you. And then the history of COVID positive cases and or deaths. It's sad to say, but one wants to look at it. And we all know it was a horribly trying time for everyone, including skilled nursing facilities, for this pandemic. So I'm not saying, oh, everybody had a lot of loss. But it is good to know kind of what's going on, and you can make your own judgments, but it's a good thing to know about. And then how are they dealing with COVID now? What are they doing? Are they quartering off areas? Do they have any COVID in their facility at the time? And if they do, what are they doing about it? Or what would they do? And are they quartering off, flu from COVID? How is it all working there? So you have a good understanding of how that specific site is dealing with this pandemic.
Nicole,
All
before
right.
you move on, I want to read to you from the chat. Joseph McGovern has
Oh,
said,
yes.
backtracking to the therapy services, Medicare guidelines have changed regarding therapy services over the past year. So confirm minutes per day and days per week of therapy.
I'm not quite sure I understand. Can you come off mute and explain to me a little
Yeah,
bit more?
can you hear me?
We can.
Okay, so just from working I'm an occupational therapist with a history of working in the nursing centers and now doing home care. They've changed how they delivered services. It used to be 6 to 7 days a week, 2 to 3 therapies a day between the physical therapy, the occupational, and the speech therapy. So Medicare has kind of driven the changes to how therapy services are provided. And on top of that, with a lot of the therapies being provided in the rooms compared to the rehab gyms, it really has changed on the delivery of a lot of the reason why a lot of families went to the nursing homes, nursing rehab centers in the first place. So if they could really ask that question of like, how are they doing their therapies as well?
That's a really important question. Thank you for bringing it up. You're absolutely right. I know with my clients, we actually had them discharged because they weren't really getting any more services than they could have gotten at home. And
Exactly.
she's much more comfortable at home. So that's a really good point. Thank you for sharing that with us.
Joseph and Nicole, it's also important to realize that if there's a break in the care and they miss 2 sessions, or they miss, I think it's 2 out of 20, is it? Joe, you probably know this better than I do. It will stop the coverage of therapy. And if there's not an underlying nursing condition, then Part A coverage may stop. If there is, like a PEG tube or a trach or something along those lines, some sophisticated nursing requirement, they can drop down to a lower category of care and still remain on a Part A stay. But if they're there just for the rehab, the coverage could stop.
The coverage is
distressing.
Yeah, the coverage, that there've always been problems with two consecutive days or 3 consecutive days of missing therapies without justification. They always run the risk of stopping therapy services. And at that time, a lot of the nursing centers would either discharge back to the hospital because it was something that medically that they couldn't handle, or that they didn't have the skills to meet at that time, or justify some other type of patient education, family training, some other type of maybe being involved without necessarily a hands-on exercise program, walking program, whatever the case may be.
Yeah.
And
and the other thing is that for Medicare, as far as I understood, I don't think it's been lifted yet. If your care was cut short or in any way interrupted due to COVID, whether it's your diagnosis of COVID or the facility's capabilities, right? They won't stop the coverage because they put that as a special aside. Does anybody know of that changing recently?
There was another thing also for anybody that has a family member in a long-term care setting. They wanted to reduce the hospitalizations. So Medicare actually took somebody that was maybe a traditionally Medicare Part B patient. not go to the hospital, and transition them to Medicare Part A. So you didn't need that 3-day qualifying stay.
Right. Absolutely. That's the other thing. So that's still in effect as far as
That is
I
still in
know.
effect.
Can you repeat that? I was a little bit unclear on what you just said.
So if there is a long-term care, if you have a family member that's in the long-term care of a nursing home,
Right,
and they have a medical situation that develops so that they don't want to send them to the hospital,
right,
or they're trying to reduce the hospitalizations, Medicare B usually Medicare A covers like a new acute injury, a new acute, they can be transitioned to Part A program versus staying on a Part B program. And then it's a different payment source. It's a different entitlement to a number of therapies that they're allowed for.
Typically, it'll switch from Medicaid payment to Medicare under a Part A stay, but what they're doing is they're waiving the 3-day hospital stay requirement
well,
so
they,
that they qualify, so they don't have to go to the hospital.
well, I know that the 3-day hospital stay has been waived since COVID. That's
Right.
been in effect
Correct.
for almost from the beginning.
Right. So it's the same kind of thing. So rather than having your 100-day stop, it's considered an interruption due to COVID. And then so you don't have included with that is that you don't need another hospital stay. You can get your rehab and it won't be taken against you those days.
And can I also just say something on here, because you
Sure.
have great points here, a history of COVID positive and deaths and stuff like that. It would be great if, and maybe I'm jaded after all these years. I would say to that, trust but verify if you can, because they're not going to be that willing to be sitting down and going over exactly what the, what their background is. And I
Oh,
told-
absolutely. Because the only thing we have is the list that we give. I'm not suggesting that
Right.
they're going to be like, okay, let me tell you, it's been, I'm going to look it up. But but and I think it's in part of the resources that we have actually that we're giving at the end. So you can look up how many, that's what they say. We don't, I mean, nobody knows for sure. But that's the list.
Nicole, it's reported deaths by the facility, and it's also presumed deaths for
Right.
people who were transferred or discharged. And it's recorded, one advisory on that, they update it 2 or 3 times a week. It is absolutely important, if you're going to look at somebody with a high rate, to find out when those rates, when they occurred, because at the front end of COVID-19, a number of really terrific facilities just got ravaged by it before we even knew what was going on. And some of the better known and more competent facilities end up having some of the highest.
Right. It's kind of like what I said. It's just everybody got ravaged by it. So I'm not saying that just because they were, it's bad, but it's good information to know. So David, I'm going to have you take it away. As far as now we're in the skilled nursing facility.
Okay, where do you want me to take it to?
You're right there. You see the slide, yeah?
Yeah, no, I'm teasing.
Okay.
It's very similar to the hospital process. Discharge planning starts at admission for subacute or short-term residents. A long-term or chronic care placement oftentimes starts as a short-term under Part A coverage. Most admissions are Part A from a hospital. And then if there's no place for that person to return to, or they're not sustainable, supportable in the community, they end up becoming a conversion to a chronic care case. They stay in the nursing home, and then they apply for Medicaid long-term for payment. We're focusing primarily on the patients who actually go into a nursing home short-term and improve to the point where they can return back to the community. That's our focal point. Just like in the hospital sector, all of the same elements exist. You even more so perhaps to very quickly identify who are the key people in the organization and build relationships with them. Unlike the hospital, nursing homes thrive on relationships. And if you know the administrator, or you know the director of nursing, or you know the director of therapy, And everything isn't running just through the social worker. That's real power to an advocate and real power to a family. So I always say request a list of key personnel and work on building those relationships. Don't be shy about introducing yourself, just calling to say hello and let them know who your relative is. Oftentimes, that's all it takes to have the administrator or director of nursing just check in on that person on that case, see how they're doing. And just the very fact that they've inquired about the person elevates the attentiveness of the staff. It works. That's all I can say. It is important upon the admission process to verify all the critical information with regards to medications, treatments, diagnoses, so that there aren't omissions or modifications or deletions in the record from the hospital to the nursing home. You want to make sure that all the information that's needed to care for that person carries over in that transition. I work with Pulse, which is focused on patient safety, and they suspect, or it's been said that as much as 1 out of 3 medical errors in healthcare occurs during transition from one level of care to another. And we know that this is a critical time, in part because the discharge plan and the discharge summary is written by a hospitalist. And it's put together and packaged and sent out. And the hospital is simply focused on emptying the bed and opening it up for a new patient. The nursing home is the one that's going to live with all the problems, as is the patient, if that information isn't complete, accurate, and timely. So I always tell family members and clients, check it. It's worth it. In my own personal experience, my mother-in-law was in assisted living. She went to the hospital. She was transferred to a nursing home. Prior to that, we had spent 5 months adjusting her Parkinson's medication with a specialist from NYU. When she went into the nursing home, the hospitalist at the hospital, another good hospital, dropped 2 of her Parkinson meds from the medication list. And as a result, within basically 24 hours, she started spinning out. And it took us 3 weeks to get her cycled back in on her meds. It was unbelievable, but they just literally dropped. She had 3 different medication orders to give the right dose at the right time. And they dropped 2 of them. Mistakes happen. So that's a critical time. As Nicole had said, it's really important to identify who handles the video visits if you don't have access, but ask about visitation privileges. That will also tell you whether they have current, if they have current visitation privileges, that means they've been successful in not having any new cases. The whole process of visitation opens up the longer they have no new cases. Every 2 weeks, it starts at level 1 if there's a current case. After 2 weeks, they reevaluate. If there are no new cases, they go to level 2, level 3, and level 4. And level 4 is full visitation. So if they're on lockdown and there's no visitation, you know that they had a recent case. You don't know how many, but at least you know that it's still current. It is important to be able to ensure that you can get in touch with the folks that are going to help establish communication with your client, your relative, your family member in the facility, and to know what it is that they'll allow. In this regard, there's absolutely no question the squeaky wheel gets the grease. If you're calling, leaving messages, and you're not getting a response, it is absolutely important to climb the ladder. If you're calling recreation and you're not getting an answer, leave a message, call the director of ask for the director of recreation. If you still don't get an answer, call the administrator. It's not about getting people in trouble. It's about making sure that people are responding to you because they're inundated, they're overwhelmed. And sometimes it's as simple as making a phone call like that so they get the help that they need. Whenever going into a rehab center, if you want your client, relative, family member to wear a gown, that's always available. but most people are comfortable with their own clothing. And just know that they need 6 to 8 changes in order to have a 2 or 3 day supply of clothing. It turns over that quickly. And you want to find out how they do laundry. If they do it there, it needs to be labeled. They can typically do that for you, but it takes a while and you don't want to lose the clothing they came in with. Otherwise, they can package it and you can pick it up and take it home, do it and drop it back off. And that's what many people do for short terms. And then same thing with regards to COVID testing and vaccination. Right now, they've started the COVID vaccinations in nursing homes. They are a priority group. My understanding was testing was much harder to get in the nursing home population. I'm not sure why. I think they just assumed, everybody's at risk. So they weren't that interested in testing, but many were. But some facilities reported problems getting testing. Then the only other thing is, same as with a hospitalization or an ER visit, when you get that notice of determination of coverage, you have the right to appeal. And again, it's important to ask for it, because if you're not physically present, then you're not getting the documentation with the information that you need to file an appeal. But once filed, and it can be done with a phone call, the appeal stays the discharge until a decision is made by an independent agency. Usually it's the QIO, I think. Does that help?
That was great, David. And I will say all of the Care Answered clients in New York that are in a skilled nursing facility have had at least one dose of the vaccine. So it seems like they're doing a really great job as far as getting those vaccines out. Okay, I'm going to try to go quicker because I know we're running out of time. So the next is the transition home. This is what I talked about that we'll go over in another webinar more deeply. But reviewing the discharge plan, same as what we talked about within the hospital, right? We need to see it. We need to be able to understand it. If anything is unclear, we ask until it is crystal clear. There should be nothing left to chance. A medication list, make sure that we have that and we understand it. Have they called? Will they be calling the pharmacy for you? Will the pharmacy have that medication available at the time? Oftentimes I've had the experience anyway of them giving them a little bit of the medication to go home with to cover. But those are questions to ask. Devices for home. That's so important. Sometimes people will need, say, something as simple as a shower chair or something like that, or something as big as a wheelchair that they didn't need before they went in, and now, before they were hospitalized, I should say, and now need it. If they don't have that, they can't get home. They come home. I know I had this experience many years ago, probably 25 years ago, in which the person was in a wheelchair and they had steps home to get into their house, had no ability to do that. So, and it still happens today. So really that kind of thing is so important to have, and make sure it's already there. Not, oh, it's going to be ordered and probably you'll get it, after that person's been home for 3 days. The transportation home, how does that look? It kind of depends on what the need is. Make sure that that's all determined so that, again, there's no guesswork. People aren't waiting on sidewalks thinking they're going to be able to get home. Home care.
Nicole, before you leave the adaptive equipment thing, it's really helpful if you talk to the rehab staff in the facility, because they can provide really effective and helpful information with regards to like the type of equipment, whether it's collapsible, whether it's wide enough. They'll look at things like the width of doorways to make sure that it actually works to the place where the person is going, as opposed to, they'll think of things you didn't think of, is the point. So
Yes,
talk to the therapy staff. They're really helpful that way.
I agree. I
Sorry.
agree. And home care. So oftentimes when people come to me, or come to Care Answered, they'll be like, so we have home care, right? They said that we would get home care. Understanding what home care is, what that means. Is it going to mean, okay, we'll evaluate for home care after you're already home and then likely give you 4 hours a week? That's something that's very much likely. So for all of those who are, being advocates for their loved ones, make sure that you clearly understand it. What the gist of what I just said is likely the scenario. It's not you're going home with home care via Medicare and you're going to get 5 hours a day. That's not likely going to be the case. So you want to be able to make sure that you've researched and known what home care providers that are available and that can provide the level of care that your loved one needs. The reality is, again, it's a pandemic. There's been a lot of difficulties, especially for those of us that are on Long Island, especially in Suffolk County, getting that home care in place because it's a pandemic. I'm hoping that, and people are nervous, they're scared. On one part, your patient, your loved one, your client, they're nervous about having many people coming in and out of their home. On the other end, when you're talking about a home health aide, they're nervous about going to other people's homes. And all of it is very legitimate. So you want to make sure that you can have that care in place, whether it's from family members or from a home care agency, without trying to figure it out after they're already home.
Nicole,
Yes.
one other factor that's really prevalent today is because we don't have senior centers and daycare programs operating, there are more people at home. The demand for home care has skyrocketed and the availability of home care workers has actually dropped because some had stopped working, some got sick, etc. So it's really important to stay on top of any new caregiver that enters into the scene, providing care for your family or your clients, because many of them aren't well trained. And it's really important to just stay on top of that and hold the home care agency accountable for making sure that they're properly trained at what they do.
Absolutely.
If I could
So,
just add,
yes,
I'm sorry.
please.
Just working with people in their home. The other thing too is a lot of the home health aides that do come in do rely a lot on the public transportation.
Right.
So some of them don't drive. Some of it's harder to get to the areas that don't have railroad stations, bus stations in the community. I mean, on Long Island, you can almost get everywhere with a car, but not a lot of the home health aides have a car. And that really limits the number of available home health aides to the community.
That's absolutely true. It's always been the case. Obviously, with the pandemic, it's even more difficult. And again, on both sides, if a patient doesn't necessarily want somebody that has been on a train or a bus, and on the other side, again, they don't necessarily want to take a train or a bus to get to their location. So it's a very difficult time. There are still fabulous home care agencies that are able to staff. And you can give me a call and I can let you know of them. It does depend. Again, you're right. If you're not near a bus or a train, it's difficult. There's some agencies, I know home care agencies that are kind of figuring out ways to transport their team. So, but know that it is going to be hard to find that. And there's questions that you really do need to ask. And again, we'll go over that as well in the next webinar. When I'm saying selecting home care during a pandemic, all of those are really good points that everybody made. that are very true and clear. And it's always been the case that there is more need than there are providers of home health aides. It's so true, and it's so much more true now. So keep that in mind when you're figuring out that discharge, so that you can get the care needs met. So with that, oops, we went over our hour. This is just to let you know we're all in this together. And thank you all for being here. These are a list of some of the resources that we spoke about regarding planning and nursing homes and comparing, and just different resources to help you better advocate and assist your clients and loved ones and patients. So with that, thank you for being here with us. We took the full hour, but we're ending now, and I really appreciate you. And please, all of you, stay safe and well and healthy, and we'll see you next time. Stay tuned for our next webinars.
Thank you.
Thank
Take
you.
care.
Thank you.
Thank you.